welcome back from lunch. We all have a food coma, the ones that actually made it back from lunch. First and foremost, I wanted to, again, thank our sponsors for the support or partnership with the American Foregut Society, for putting on the exhibit hall, for the lunch and learns, for the dinner and learns. Without them, obviously, we wouldn't be here. Now it's my great honor to introduce our president of the society, Peter Kyrillis. Obviously, Peter doesn't really need an introduction, so therefore he's not going to really get one either. Peter's been, hold on, I was going to say a couple of things. Well, anyway, here's Peter.
Thank you, John, for that warm introduction. I'd like to give you a little update on the state of the union of the AFS. So we've come a long way in not too many years. We're now 500 members. It's a 2/3, 1/3 split between surgery and GI. We have 57 residents and fellows, and I think this is key because it's essential that this organization renew itself. We have developed momentum. The journal, Foregut, is now in its second year. That in and of itself is an enormous achievement. We have launched a textbook, and you may have seen posters. This should be out early next year. It's complete at this point. The research committee has awarded the first research grant, which you'll hear about at the awards committee later on in the meeting. We had a record number of abstract submissions to this meeting. Importantly, we've had 83% engagement on doc matter, which is higher than any other society has achieved. One of the initiatives which we've launched, and you've seen the little plastic flyers going around, is we had an initiative to revise the Hill grade for the evaluation of the EG junction endoscopically, now referred to as the AFS hiatus grade. Live Surgery Day. I'll describe this a little bit later on, not that much later on. Another key achievement here is the AFS is now participating in the Fellowship Council to create an accredited foregut fellowship. This was an enormous achievement in this past year, and we had a very successful motility course in June. And finally, we have launched the inaugural class of the Fellows of the American Foregut Society. And you might guess who those are going to be, but whatever. So the benefits of membership. We need members. We need more surgical members. We need more GI members. As part of membership, Foregut Journal is free. There's a monthly newsletter from the AFS. There's membership to Doc Matters. There's access to industry's latest technologies, therapies, and research projects. You participate or can participate in research and follow your outcomes through the Roars Registry. If you're a trainee, you can get a discount. Webinar access. There's a regular series of webinars. And starting in 2023, registration to this meeting will be free for all members. Speaking of this meeting, I think it's worth thanking our program chairs here. They did a tremendous job. This was a year-long initiative to get this going. Tom and Prakash worked tirelessly. These were weekly, sometimes bi-weekly calls to put this together. As with everything else in this pandemic era, it had its ups and its downs, but I think the success of the meeting speaks for itself. And these are the members of the program committee. They all got a little thin, you might notice. Aspect ratio. This is the current AFS board. And the board meets regularly to try and guide this organization. And new to the board is Stuart Speckler. I think he deserves a little more than that. You kind of went low on Stuart. So yes, welcome to the Foregut Fellowship Certification Program from AFS, ASMBS, SAGES, and SSAT. And if you know what all of those stands for, good for you. The journal. So the journal is now in its 6th issue, I believe, just came out, 2nd year. Many thanks to the editors, Phil and Brian. I can't tell you how great an achievement this is to take an idea to the 6th issue of a journal in whatever it is, 3 years that they've been working on it. That is tremendous. Thank you, Phil and Brian. Some brief metrics on the performance of the journal. We've had 80 manuscript submissions in 2021, 64 thus far in 2022, an 82% acceptance rate, pretty quick turnaround. 4 issues, 183 pages in 2021. And then there's the rest. But online usage, look at that, 3,320 full-text downloads in 2021, 8,200 full-text downloads in 2022. That's really good. And then the Fellows of the American Foregut Society. We've decided that this would be a way of bestowing an honor on the most accomplished, most serving members of the AFS, and you'll hear about this more at the awards ceremony today. The motility course in June of 2022, this is the photograph of the group that participated. This is something that is planned to continue going forward, although the exact schedule has not been finalized as yet. Live Surgery Day. Now, this is something that I did not participate in. Good thing, because they were doing real surgery across the country, I might add, simultaneously, east to west. And it was really quite successful. There was a lead-in period from April until April 12 there, where the operations went across the United States, 4 simultaneously, 3 are tracked here just to show you the outcomes of it. And within 3 days, from April 12, well, within a month, April 12 to May 11th, there were 2,000 to 3,500 views of these. So this was an enormously successful and I'm sure to be reproduced initiative. The live hands-on this morning, this is a panorama of it. Highly successful. We've had much positive feedback from our industry sponsors on this, and likely to be repeated as well. The textbook, available in March 2023. Thank you to all our authors and editors. I think this was pretty close to record turnaround time for taking something de novo to completed for a textbook. The AFS hiatus grade, Nin Nguyen, thank you. This is something that I participated in this, and I'm really very happy about it. I think this is long overdue. It is an endoscopic assessment of the integrity of the anti-reflux barrier, the hiatus. You'll hear more about this from Nin a little bit down the road in this meeting. These are the committees and committee chairs: advocacy, bariatric, clinical practice, lifelong learning, membership, research, and robotics. All of the committees have been quite active. We need more. We need more participation from all of you. These are the outgoing chairs, Prakash, Eric, and Dimitri. But join a committee. Express your interest. Get involved, please. Sponsors. John said it already, I'll say it again. Thank you. This meeting could not occur without the support of our sponsors. We've had quite a few of them. Let's give them a round of applause. And with that, it is my real pleasure to introduce my successor. Reg Bell will be the president starting in about 2 minutes and extending for a year. Reg has really been instrumental in this organization from the get-go, and he may only be becoming president right now, but let me tell you, he's been there for quite a while. Reg?
Peter, thank you. It has been a real honor to be part of this whole movement in society. And it's really started organically when some of us sat down together and said we really need to get surgeons and GIs together. And I think it was probably best expressed by Blair Jobe, who said this needs to be a grassroots movement. And we started as really a grassroots movement. And it's incredible to see how it has grown since then. And it's been due to basically an organic get-together of people that have had a similar dream and a similar ability to work together. And so it's really not been any of us in particular that have been the leader in this. It's been the whole system that has been a leader to it. And so first off, I want to thank all the board members and those that are here. I'd just like to have you stand up and say thank you to them. So I think there are a few maybe that came after lunch. And it also wouldn't have happened without some help from my better half, Kate, who's been the wonderful executive director for the society. And to help from Affinity Solutions, who have worked closely with Kate. So Rosaline, Becky, Skylar, I think those are the ones that I can see in the back there. Thank you. You've done a tremendous job. But mostly I want to thank all of you who are here, because it's really you that make the society. If it were just us, we'd all be standing up here drinking cheap beers, just a few of us at the bar. But it's really you who make up the society, and because it's a specialized society, I think it's especially important to encourage and really ask for your involvement and tell you that we expect your involvement in the society, because everyone's opinion is valuable. Even if it's, I don't know what's going on, you guys aren't explaining it to me well, that's valuable input to us. So please be engaged. This is really, I think, the most important thing we can do to ensure that the growth of the society is just engage you, find ways to engage you. And if we're not finding good ways to engage you, please let us know. And I also want to recognize the trainees who are able to come this year. I'll just ask those of you who are trainees to stand up, because I think it's wonderful. A few of you? Awesome. Because you especially are the future of the society for us, because the gray hairs amongst us are eventually going to go on to other things like fishing and other things. So anyway, thank you all. It's an honor to be here, and I really look forward to a fantastic next year. And I want to say thank you especially to Peter, who saw us through really 2 years of something incredible that hopefully we'll never experience in our lifetime in terms of COVID, and helping to keep the society organized, projected. He was really probably the foremost in insisting that we find ways to be in person despite this whole pandemic. So thank you, Peter, and I'm honored to take place after you. Congrats.
Well, congratulations, Reg. A couple of things here. So as Reg said, we started this as a grassroots movement, not thinking that really it would go anywhere. I mean, we saw a need for it, don't get me wrong. It all made sense. It sounded like a good idea to bring GIs and surgeons together, but would it take off? 50-50 at best. And to our surprise, it took off. That grassroots movement spread like rapid fire across the country. People were reaching out, wanting to partake, form committees, join. And then probably the most surprising thing is it spread across the pond. It spread to Europe. Europe guys reached out and said, how do we start our own society, a European foregut society? And then quickly from there, they got it launched up off the ground, and it started to spread throughout Europe. And so we're lucky to have Sebastian Schopman and Luigi Bonavina here, who are instrumental in starting up the European Foregut Society, based on what they saw was happening with the American Foregut Society. So it's my pleasure to introduce Sebastian, who's been a longtime friend. He's professor of surgery at the Medical University of Vienna. He's currently the vice president of the European Foregut Society and the soon-to-be president. We just haven't figured out what the definition of soon is yet. But Sebastian is going to, I think, give us an update on the European Foregut Society. Sebastian? Thank you, thank you.
Thank you so much, John. Thank you, John. Peter, thank you very much for giving us a little space to show a report how the little sister is developing. Reg, congratulations. Thank you. Well, I brought some slides to show you how we are doing in Europe, which looks like this. And it's quite hard at the moment to draw borders in Europe, unfortunately. However, if you try to figure out a GERD Europe, this is how it looks like. There's 700 million people, 48 different countries, 24 different languages, around 150 million people suffering from GERD, 48 different healthcare systems. We have no idea how many patients with GERD are treated with medication, how many people are treated with surgery. If you take PPIs, this will cost you none to 150 euros a year. If you go for fundoplication, some patients will have no costs, some will have to pay 20,000 euros. There is no country in Europe that has a quality control for surgical GERD treatment, and there's no country in Europe that has a standardized upper GI surgical education plan. What we have is we have 900% increased GERD super specialists, and we have 900% increase in web page presence of GERD centers. So this was a situation where it was quite unsatisfactory. So this is where everything started. At some point, some of those who were mostly unsatisfied just sat together. This was in Vienna. We went, and most of you already also enjoyed it. This is Tafelspitz. You have this in Plachuta, so if you're there, you have to have this. And we had a lot of thoughts. And after maybe 2 beer, maybe 2 bottles of white wine, we remembered our friends at the AFS and remembered them having a great thing growing up and remembered this great event in Las Vegas all those times. And so what we did some traveling. I went to John and we had some chats and we discussed, and he really tried to motivate us and said, well, this is something that can also happen in Europe. So we went back in 2020, we founded this European Foregut Society. It's not that easy because regulations, all pan-European, are very, very different, but we got it, and we got a key mission statement, which is quite similar concerning the aim to the AFS for sure, with a multidisciplinary thing. We want to improve the treatment and the diagnosis of GERD, foregut disease, for example, and we got a perfect president. We found Lucian after some telephone calls, 10 of them, he said, yes, he will be the president, that's perfect. Then we started sharing the work, because it's a lot of work. We established an executive committee board and EFS board out of, I think this is 18 different countries, and we started traveling, phoning, doing Zoom calls quite a lot to set up a multidisciplinary advisory board. Again, 24 different countries, different languages, we set up this. And yes, we did our first meeting. We did our first meeting last year in Vienna. It was hybrid. It was between 2 of those COVID peaks. And for us, it was very successful. We had like 210 participants. And this was where the AFS did its second boost. And this is also responsible to those three. So I don't know if Kate is there. I regularly see her running around. So thank you, Kate, so much. Thank you, Kate, so much. And thank you, Kate, so much. And thank you, Reg, and thank you, John. This was real improvement. From this moment on, we knew that we could also do it. So this is what we're going to look for next years. We're going to establish a Pan-European Education Committee. We're a scientific committee running 2 European-wide surveys. This is tricky in Europe. We're trying to get some kind of central organization for forgot workshops, and we're going to establish something like a teaching center. And yes, we're going to have our second annual meeting. This is like in 5-6 weeks from now on. We'll be in Belgrade. We have a very good program set together. Again, some of our friends from the AFS are going to come there. And we will have some time to experience the beautiful Belgrade during this time. We already settled the next meeting places. It will be Milano, hosting Professor Bonavino there, and then we'll have Barcelona, London, Berlin, and Zurich. This is our plan, and this is our second plan. We hope that this great cooperation, this friendship will grow and grow and grow, and thanks again for the support from AFS to AFS. Thank you very much.
Fantastic.
Yeah, thank you.
All right, well, thank you, Sebastian. Like I said, the European Forgot Society taken off has really been, I think, reflective of the need for this society, whether it's the American Forgot Society, European Forgot Society, or Asia has reached out with similar interests. So anyway, I think we're onto something. Well, with no further ado, we're going to get to what I'll call the main event. Phil? What? Am I allowed to say that? Okay, because you already just said it. So one of the things that wasn't mentioned is the Forgot Journal that has been very successful in a short period of time. European Forgot Society is now going to be part of that journal. So it will be their home journal also, which will help both societies establish the societies and increase publications. So speaking of publications, now we're ready for the main event. And the main event is the abstract presentations. To chair that is going to be Lee Swanstrom, obviously the guru of everything, but has really taken the scientific portion of this society and run with it. So incredible appreciation for all your work you've done, Lee, in pushing us to do this, to put on abstract presentations every year. So with that, Lee, I'll let you take over and run it the way you see it.
Thank you, John. Appreciate that. And I can only second what you say. I think one of the biggest services that medical societies provide is to create a foundation for academic promotion. And I'm very happy that AFS is committed to doing exactly that. So we had a very robust submission this time. We had lots more abstracts than we hope to present. And in the future, we're going to push for more abstract presentation time for oral abstracts. I encourage people to look at the posters that are out there, electronic posters, and then enjoy those as well. Appreciate the young surgeons, young gastroenterologists that submitted that, and I really appreciate our abstract reviewing group because they went through a lot of abstracts to kind of go. Finally, I have to say, give a shout out to my co-chairman, Mimi Canto, who unfortunately can't be here, but Mimi was very essential to running this as well. So without further ado, I'm going to invite our presenters to come out. They're going to give a 7-minute presentation. We'll have a few minutes just for 1 or 2 questions afterwards. And hopefully we'll be seeing their presentations published in Forgot, the journal. So let's go ahead and get started. So our first presenter is Samo Saith, and he's presenting on sudden onset achalasia after a COVID-19 infection.
Thank you. Thank you very much for the AFS for this incredible opportunity. Thank you, Dr. Corellis, for the last amazing 2 years. They've been challenging, but you plowed through, and congratulations to Dr. Bell. Looking forward to the future. Again, thank you for this incredible opportunity to present our research that I'm very excited about this project, sudden onset achalasia after COVID-19 infection, PCR analysis of esophageal muscle tissue. I should have added sudden onset rapid development achalasia, and I will show you why. So we know that achalasia has been linked to viral infection. Examples of those are HSV1, measles, human papillomavirus, and varicella zoster, with the evidence being strongest for herpes viruses and papillomavirus. Since 2020, with the beginning of COVID-19 pandemic, we have seen cases of sudden onset rapid development type 2 achalasia post-COVID-19 in previously completely symptomatic patient from an esophageal standpoint. Family confirmed that they were totally normal from that standpoint at 2 medical places. And so we aim to evaluate and compare esophageal muscle tissue for SARS-CoV-2 infection from patients with and without post-COVID-19 onset of achalasia. This was a prospective study at a single medical center. Included 3 groups. Group 1, the group of interest, is sudden onset achalasia type 2 post-SARS-CoV-2 infection. Group 2, long-standing type 2 achalasia, they developed COVID later, that came after their achalasia onset. And group 3, long-standing achalasia type 2 with no known SARS-CoV-2 infection. Multiple tests were done at negative time periods. And we obtained muscle biopsies from the LES area during peroral endoscopic myotomy procedure. The total mRNA was purified from formalin-fixed paraffin-embedded samples, and we assessed the presence of SARS-CoV-2 nucleocapsid, the N protein, and the spike S protein, in addition to inflammatory markers by reverse transcriptase PCR technology using the RNA-EZ kit from QIAGEN. And this project was IRB approved at KU in Kansas. So our primary analysis outcome was to look at the mRNA for N and S protein in esophageal muscle tissue, and the secondary outcome analysis was to look at the mRNA for the inflammatory markers, specifically NLRP3, interleukin 18, and TNF. And we use independent samples, Kruskal-Wallis test, to compare outcome between the groups using GraphPad Prism 9. Values are expressed as mean plus minus standard deviation, and a t-value less than 0.05 was considered significant. mRNA is reported as relative expression and normalized to 18S, which is the standard way of reporting this. So looking at the groups, group 1, the group of interest, achalasia onset after COVID-19, we have 4 patients, predominantly male. In this group, 2 of the patients had confirmed SARS-CoV-2 infection. The other 2, though were not tested, they were suspected to have SARS-CoV-2 infection based on their exposure history. Group 2, this is the group that type 2 achalasia, they developed COVID later, 6 patients, again predominantly male. And group 3, this is achalasia type 2 with no known SARS-CoV-2 infection. Group 1 was younger. Looking at the N protein mRNA, significantly higher at 625 folds higher compared to group 2, which had some, and group 3 that had none. Looking for the spike protein mRNA, it was elevated in group 1, some was seen in group 2, and none in group 3. This did not reach statistical significance, and I will go over why that might be. Looking at the graph, you look at panel A, that is the N protein mRNA level. Blue is the group of interest, achalasia after COVID-19. Red is group 2, achalasia that developed COVID-19 later, and group 3 is the achalasia type 2 with no known SARS-CoV-2 infection. The N protein was significantly higher in all 4 patients in that group. The S protein, although there's overlap, but it was higher in the 2 patients that would confirm to have SARS-CoV-2 infection. The other 2 who were not tested, they overlapped with group 2. Looking at the inflammatory markers, the NLRP3 and TNF were significantly higher in group 1. So just to go over how rapidly they develop, completely asymptomatic, got COVID, you look at patient 1, within 1 and 5 months, full-blown achalasia, and the other patient between 2 and 5 months, a lot of weight loss and Eckhart score pretty high. So we report here the sudden onset and rapid development of achalasia after SARS-CoV-2 in 5 previously asymptomatic patients. 4 were included in the study. The 5th one was at a different hospital, and esophageal muscle tissue was not available for analysis. The PCR showed that esophageal muscle mRNA showed higher levels of the N protein in all 4 confirmed and suspected cases in group 1, and also higher S protein in the 2 confirmed cases of SARS-CoV-2. What could be a possible mechanism here? It's being shown in upper airway tract that CD8 T-cell activation specific to SARS-CoV-2 occurs. But also we know this mechanism has been thought to be causing achalasia by CD8 T-cell mediated destruction of ganglionic cells. So could SARS-CoV-2 with its affinity to ACE2 receptors that are expressed on neurons is similarly triggering an inflammatory reaction that eventually causing achalasia? This is a hypothesis. We are not claiming this. Our data did not assess this. But what is supportive here that the inflammatory markers were increased in the achalasia post-SARS-CoV-2 infection. Limitations, small sample size in each group. We know achalasia is rare, and achalasia after COVID-19 is probably more rare. We could not make a conclusive assessment about the status of ganglions because our biopsies were partial thickness using biopsy forceps. This requires full thickness sampling. There was a large amount of variation in the presence of the spike protein, especially in group 1, and that did not reach statistical significance comparing to group 2. There have been 11 variants of SARS-CoV-2 so far. They predominantly differ in the spike protein. So it is possible that our assay was not detecting S protein for different variants, and that would only represent the amount of the S protein mRNA in our data. So as a conclusion, our data implicate a connection between SARS-CoV-2 infection and achalasia development, and possibly identify a previously unknown consequence of COVID-19 infection. Thank you very much.
So great talk. Congratulations. We have time for one question from the floor, if anybody wants to jump up. I might propose one question that sounds very similar to the inflammatory mechanism that's been described for Chagas disease, having this similar. Did you look at any of the literature on Chagas, inflammatory markers in that? And
not that maybe specifically for this presentation, but I think that's a logical mechanism, whether it's Chagas or not. Chagas seems to take a long time to develop. This group, I mean, they developed rapidly, and we made sure we rule out cancer in those folks, and they were mostly young. So,
okay, great. Thank you, Sam. Oh, one more question.
Absolutely. So I do POEM myself, so I have access to the area, and I just pass the forceps, I biopsy the LES area. It bleeds a little bit, but that amount of blood is not impressive when you see other type of bleeding during POEM. But full thickness, once you cut, you could get a full thickness, but that's a cautery effect that I'm worried that might cause an issue. At the time of the POEM, before doing a myotomy, finishing the tunnel before the myotomy, getting bites.
Is there a possibility it could be contamination? Saliva, of course, has a heavy viral burden. And
good question. If that is the case, then the other two groups, the group 2 levels should probably be higher as well. So again, this is, maybe there is a link. We're not claiming any causality or whatnot, but I think it is causing something that patients are totally healthy and they get COVID and they rapidly develop. I was talking to some of my colleagues and some said, yeah, I think we have seen that as well. So I think you'll see more and more over time.
all right, thank you, Samo.
I appreciate it. Thank you.
So our next presenter is Jessica Wu, who's going to present on magnetic sphincter augmentation for fundoplication, analysis of 1,165 patients.
Hi, I'm Jessica Wu. I'm a general surgery resident at the University of Southern California, and today I'll be presenting for my co-resident, Jack Silva, and I want to thank AFS for this opportunity to present our study. We have no disclosures. So, the magnetic sphincter augmentation, or MSA, has been around for over a decade, and it has evolved over time. The LINX reflux management system gained its CE mark in 2008, and the FDA approved it in 2012. In 2013, the clasp device and the laparoscopic sizer were identified and introduced. A full crural dissection became standard of care in 2017, and in 2018, we realized the indication for patients with hiatal hernias. By 2021, over 30,000 devices have been implanted worldwide. Over the past 10 years, while MSA has been growing in popularity, fundoplication has been a mainstay of anti-reflux surgery. The decision as to which of these procedures to perform is typically based on preoperative patient factors and surgeon preference. However, there's a paucity of data to inform us among which of these surgery options we should do. Prior studies have shown that perhaps the Nissen's fundoplication provides a more robust reflux control than a partial wrap, with the trade-off of a higher incidence of post-operative dysphagia and gas bloat. But where does the LINX fit into this picture? Is the side effect profile and reflux control more comparable to a complete wrap or a partial wrap? Or is it a mixture of the two? To answer these questions, we decided to query our own database of over 1,000 patients who have undergone anti-reflux surgery since the inception of the LINX device. Our objective was to define the efficacy and side effect profiles of LINX, complete fundoplication, and partial fundoplication. Also, we wanted to determine the risk factors in this patient population for poor post-operative reflux control using the GERD HRQL score. We hypothesized that similar outcomes would be achieved among all 3 treatment options. We performed a retrospective review of 1,165 anti-reflux surgery patients at 2 high-volume centers in South California. The same surgeons operated at both centers. All patients underwent magnetic sphincter augmentation with LINX, a complete fundoplication, or a partial fundoplication. Patients answered both preoperative and postoperative GERD HRQL questionnaires. The decision as to which procedure to perform was typically based off of the surgeon preference, depending on preoperative variables including symptom severity and preoperative dysphagia or dysmotility. These 3 cohorts were compared to identify differences in preoperative variables, perioperative outcomes, and long-term postoperative side effects and reflux control. Finally, multivariable logistic regression was performed using the entire study population to determine risk factors associated with poor postoperative reflux control. This is defined as a higher GERD HRQL score at 1-year follow-up. So this is a table showing the differences in preoperative variables among the 3 groups that were statistically significant. As you can see, the MSA patients had the lowest incidence of preoperative dysphagia, while partial fundoplication patients had the highest incidence. MSA patients also had the highest preoperative DeMeester and GERD HRQL scores, while partial fundoplication patients had the lowest DeMeester scores. Complete fundoplication patients had the longest preoperative symptom duration and the highest incidence of prior fundoplication. Partial fundoplication, unsurprisingly, had the most mild reflux symptoms. This was demonstrated by lower PPI use, less heartburn, and less globus sensation, and less esophagitis on pre-op EGD. And this table here at the bottom shows the factors that were similar across all 3 cohorts. This includes BMI, reported cough, reported hoarseness, a history of autoimmune disorders, the presence of a hiatal hernia, and the Hill grade defined on EGD. This table shows a comparison of perioperative variables and long-term postoperative outcomes. As we know, MSA is typically associated with a shorter operative time and shorter length of stay. Complete fundoplication patients had a higher overall postoperative GERD HRQL score compared to LINX or partial fundoplication patients. However, complete fundoplication in LINX patients had similar rates of improvement in GERD HRQL score postoperatively. It is important to highlight that partial fundoplication patients had a lower percent of improvement in GERD HRQL score compared to complete fundoplication in LINX patients. Lastly, postoperative side effects like heartburn, dysphagia, gas bloat were not significantly different between the 3 cohorts. However, these side effect reports were from the GERD HRQL questionnaire, and this is not a validated model or method of determining these postoperative symptoms. Multivariable regression was then used to identify independent predictors of higher postoperative GERD HRQL scores. First and foremost, I would like to highlight how type of anti-reflux surgery performed was not an independent predictor of higher or lower postoperative GERD HRQL scores. Compared to those who had GERD for over 10 years before surgery, a shorter duration of symptoms predicted a significantly lower post-op GERD score. And lastly, patients on PPI preoperatively or those who have reported having heartburn were both independently associated with a high post-op GERD score. So in summary, our study shows that surgical approach chosen for anti-reflux surgery was dependent on patient characteristics. When comparing the 3 different anti-reflux procedures, MSA and complete fundoplication were noted to have the greatest percent improvement in GERD HRQL scores. Patients who underwent partial fundoplication did not show as significant of a change in GERD HRQL improvement. However, patients who did undergo partial fundoplication did have clinically similar postoperative symptoms. Based off logistic regression model, the choice of procedure was not an independent predictor of reflux control. So in conclusion, proper patient selection should take into account symptom severity, duration, side effect tolerability, demographics, and comorbidities. Using these factors, we can make a more informed decision between the different anti-reflux surgeries results in an acceptable balance between reflux control and side effects. Thank you.
Thank you, Jennifer. Nicely presented. Congratulations on your good work. It looks like we have a few questions from the floor.
Sounds good.
Hi, great job.
Thank you.
Quick question, what kind of partial fundoplications were done?
Yeah, usually at our institution we do the Watson, but we didn't really divide between toupee, door, or Watson for this study.
So when you said partial fundoplication was inferior as far as resolution of GERD symptoms, and the percentage in GERD, which one are you referring to? All 3 were lumped in there?
Correct. All 3 were lumped as partials.
Thank you.
Good. Another.
Excellent work from a great place, Shamit Middle. Just a question. I'm assuming these were all the foregut hiatal hernia procedures done at USC during this period. So I'm going to assume there will be a fair number of those type 3 volvulized stomachs that really don't have a large amount of preoperative reflux symptoms. So their GERD HRQL would probably be better than those people who presented for reflux. So their improvement of the GERD HRQL, which you bring up, is going to be less because they started very low. So how do you address that part of the patients who, I'm assuming the older patients with big volvulized stomach ended up having partial fundoplications more likely. And that could explain that's why they had less improvement rather than because they didn't have bad reflux earlier.
Yeah, and that's a really good point, and I think that's something that, using the GERD HRQL scores, we are not really able to capture that. But
So do you have a comparison where they started off individually?
we have the scores that we started off, and then we did post-op scores after. Yes.
Sure.
Great talk, Trip Buckley, Austin. I know it's not standard care for us to go and get pH studies after we've done surgery, but I know y'all do them not infrequently. I'm wondering if you were able to take a peek at that data and let us know where each of those kind of fell out in terms of MSA, partial and total.
Yeah, this database that we created didn't take that into account, but I think that would be something good that we could add for sure.
Thank you.
All right, thank you very much,
Thank
Jessica.
you.
So now I'm going to call Benjamin Wadowski up to present on his utility of water siphon maneuver during barium esophagograms.
All right, sounds like it's working. All right, good afternoon, everyone. My name is Ben. I'm a general surgery resident from NYU. Today I'm going to talk about something a little bit different, and that's the water siphon maneuver and whether or not it adds value in diagnosing reflux at the time of barium esophagography. And I have no disclosures to report for this study. So some of you may remember an ad campaign by Google where they argued that they could save something like 1 billion hours a day by adding an autofill feature to their search function. And I don't know whether the data ever bore that out, and I'm certainly not going to be speaking on something of that magnitude, but in a similar vein, I think this study is driving at maybe we can take something that's already fast and easy and straightforward and make it even more efficient, even more streamlined, and even more high value for what we put into it. And so the water siphon maneuver, as many of you may be familiar with, is a provocative maneuver during barium esophagography designed to elicit reflux when it's not spontaneously observed on the swallow. Previous research out of our radiology group at NYU has shown that the maneuver increases sensitivity for GERD using histology as a gold standard. They found this sensitivity with this maneuver as an adjunct increased sensitivity from 21 to 71%, pretty substantial. Whenever you increase sensitivity, you're going to lose some specificity, but the reduction was modest from 86 to 65%. As I said, it's pretty fast, it's pretty well tolerated adjunct. There are no published evidence of adverse reactions to forcing people to do a swallow while rolling over, and so our group routinely does it when they don't see GERD spontaneously. Briefly going into the technique, for those of you who are not familiar with it, after you perform a standard swallow, you clear the esophageal lumen of contrast and you put the patient supine. You give them a cup of water to the right of their head and a straw, and then under fluoro you have them roll over toward the cup while drinking from the straw. And the test is considered positive if you see reflux of the barium up into the esophagus, occupying the entire lumen as showed there on the right. And so there is some controversy over this, more about barium swallow in general, but particularly about the water siphon maneuver. For example, gastroenterology societies don't recommend barium swallow as a sole diagnostic test for GERD. The radiology literature is a little bit less concrete on that, and as I pointed out with that previous study and some other ones do support adding the water siphon maneuver to elicit reflux when it's not evident. There's less controversy over the gold standard for diagnosing GERD with non-invasive testing, which is ambulatory pH testing. And so the question that we sought to address with this study is, does the water siphon maneuver add value in diagnosing pathologic GERD? And to put it differently, the objective was to compare the water siphon augmentation to gold standard in a head-to-head comparison. To do this, we looked at sequential patients at our institution over 4 years who had both tests, an ambulatory pH test and a barium esophagram with water siphon maneuver, We didn't discriminate in what type of pH testing that they had, either impedance or wireless pH testing. And the water-siphoning maneuver in all of these patients was performed, as I said, when GERD wasn't spontaneously observed on the barium swallow. For the purposes of definitions, we use an esophageal acid exposure time of over 6% to define GERD based on the Lion consensus, and we use standard techniques for statistics to calculate our data. In terms of our results, our overview of the demographics is shown there in the table on the left. We had middle-aged patients, predominantly female, predominantly Caucasian, which is consistent with our referral base. The esophageal acid exposure time for the group was a median of 2.6. About a quarter of these patients, 27%, were diagnosed as having GERD based on pH testing. Remember, none of these people had spontaneous reflux on their barium swallows. But 68% of these patients did have a positive water siphon maneuver. In the graph on the right, you see distribution of total esophageal acid exposure. There's no significant difference between patients who had a positive versus negative water siphon maneuver. You can see that the distribution of people that were positive on pH tests is fairly similar between those two groups. Dichotomizing it instead of looking at a continuum, it's still no significant association between having a positive pH test and a positive water siphon maneuver. In terms of how well the water siphon maneuver actually performed in this patient population, the sensitivity was comparable to the previously noted study at 64.5%, but the specificity was kind of abysmal at 30% in this patient group, with an overall accuracy of the test of around 40%. And so this is not early data, but this is just the kind of the surface of the analysis that we'll be bringing forward in the manuscript. But it is the largest study to date directly comparing the water siphon maneuver to ambulatory pH testing for diagnosis of GERD. And notably, there was a high proportion of patients who did have GERD based on pH testing who had a negative swallow. So there is a clear need to bridge that gap in identifying those patients who have the negative swallow. However, based on this data, though the water siphon maneuver does consistently improve the sensitivity compared to the spontaneous observation, given the specificity and the overall test characteristics, we can't really call the water siphon maneuver adjunct a reliable test in diagnosing pathologic GERD. And so we will gently suggest, based on this data, that the routine use of water siphon maneuver during barium swallow to diagnose GERD should be abandoned. And that flow chart there on the bottom, barium is good, water siphon is a little bit better, but ultimately pH testing is still the most accurate, and so we need a slightly better way. And with that, I'll thank our group at NYU and everybody here for having me, and I look forward to your questions. Thank you.
Fascinating study, and congratulations on the honesty of reporting negative results. So, well done. Questions from the floor? I might ask one. You know, the difference between pH testing and why it's a gold standard is we do pH testing, whereas we have to depend on radiologists to do barium studies, and quality has always been an issue since we don't have any control over that. Do you think that had any impact? Did you supervise these barium swallows, or are your radiologists well trained in doing them?
I will say our radiologists are well trained. We have a large radiology group, and it's large enough that we have expert radiologists in the field of foregut radiology, and so I wouldn't pin the negative data on the quality of the swallows or the quality of the water siphon maneuvers. I don't think it is a technical error that would contribute to that.
Okay, great. Dr. Smith.
Dan Smith from Atlanta. Ben, I like this a lot for a couple of reasons. One, increasingly payers are looking over our shoulders, questioning everything we do, and looking for reasons to challenge our diagnosis, especially if our diagnosis might indicate an intervention. So in my area, I may have a payer question a diagnosis even when it's made based on pH because a contrast study says something different. And they're doing this post hoc sometimes to wonder if the diagnosis is correct. My question is, how about spontaneous reflux? So this is a group who has a provocative maneuver who didn't have the spontaneous reflux. Do you have any data on the finding of spontaneous reflux on a contrast study and whether that correlates?
I don't have it as part of this because by definition, all of these patients had no spontaneous reflux. However, that would be a fairly easy thing to pull We can query radiology reports for spontaneous reflux on barium swallow and do a similar comparison with the pH studies. That's a great suggestion. I appreciate it.
All right, very good. Thank you very much. So Dr. Sammo gets to have a second presentation. Congratulations for that. You didn't cheat or anything, did you?
Not that I'm aware of.
Anyway, it's going to talk about general anesthesia's effect on flip measurements.
Well, thank you. Thank you very much for the opportunity to come to the podium again. And I'm so glad your project found negative findings, because as a gastroenterologist, I'm so happy about that outcome. So to look at general anesthesia effect on function lumen imaging probe measurements for achalasia type 2 and type 3, I just don't find type 1 anymore, so we don't have any type 1 in this project. Disclosure. So FLIP is an adjunctive tool to further aid in the diagnosis and management of esophageal motility disorders, including achalasia. But the effect of general anesthesia on FLIP findings is unclear, so we aim to study the effect of general anesthesia on FLIP in treatment-naive achalasia patients. We prospectively collected data on consecutive treatment-naive achalasia patients who underwent FLIP evaluation under monitored anesthesia care with propofol, and then had FLIP again under general anesthesia within 3 months at the time of their peroral endoscopic myotomy at a single hospital. This extended from March 2021 to May 2022, about 14 months. So the flips were performed using the 16 centimeter catheter, and the flip bag was sequentially inflated by 10 ml to a max volume of 70 ml with wait time about 30 to 60 seconds between each volume. And video recordings were looked at again later by a single operator. All achalasia cases were diagnosed by the current version of the Chicago classification, version 4, and this was approved by IRB at KU in Kansas. So we used Wilcoxon sign rank test to compare flip measurements under MAC general anesthesia using SPSS version 27. We look at the flip distastability index DI at 60 ml, EGJ diameter at 60 ml, and max EGJ diameter, and we also look at the flip bag pressure at 60 ml and maximum pressure that reached during the flip study. Findings are reported as median with interquartile range. We had 13 patients, predominantly male. That's, achalasia more common in male than in females. Median age 69. In terms of achalasia type, 5 were type 2, pure type 2. 7 of them were type 2, the spastic component, and we consider those as type 3. That is an example of that as the bottom picture. And only one case had the classic type 3 achalasia, findings on manometry. So going over our finding, the EGJ distastability index at 60 ml overall, there was no difference. Looking at type 2 achalasia only, there was some variability, but still no difference. And looking at type 3, there was still no difference. But you could see the DI in type 3 is lower than type 2. That's because more pressure in the bag, that means your DI goes lower. Looking at EGJ diameter at 60 ml, still overall no difference under MAC and general anesthesia. Looking at type 2, still no difference, some variability again. And looking at type 3, again, no difference. Looking at the max EGJ diameter, only 12 cases. 1 case was excluded because the max diameter was not available. But overall, there was no difference. And when looking at type 2 achalasia, there was no difference. And looking at type 3, there was no difference again. Looking at the pressure at 60 ml, overall there was no difference. Looking at type 2, there was no difference again, and looking at type 3, there was no difference. You could see the pressure is higher in type 3 than it's type 2 because that's the spastic achalasia, and it only makes sense to squeeze harder on the flip back. Looking at the max pressure, one case was excluded because that value wasn't available. So overall, there was no difference. And looking at type 2, there was no difference. And looking at type 3, there was no difference. But again, the max pressure in type 3 was higher than type 2. So our data show that there is no effect of general anesthesia on flip measurements in achalasia type 2 and type 3. This makes sense because paralytics that might be used for induction of anesthesia, or even if they are used throughout the case, they exert their effects on striatum muscles. And what the flip evaluate is mostly mid and distal esophagus, including ileus, which is predominantly smooth muscle. This is important for endoscopists who do POEM or surgeons who do hilar myotomy. If you have a concern about general anesthesia having effect on flip that might give you false reassurance that your myotomy is adequate, our data goes against that, and there is no effective general anesthesia on flip in achalasia. Again, small sample size and lack of achalasia type 1 in the study. I'm not finding any type 1 achalasias, and I was talking to Dr. Corrales, and he thinks we just cleared all of those and increasing awareness about achalasia. We are checking them earlier, and we are finding more and more type 2. So as a conclusion, general anesthesia does not affect flip measurements in achalasia type 2 or type 3. Thank you very much.
Question from the floor? Might ask just one detail of performing it. Do you use the same protocol for both? Or do you, in your preoperative, is it done in left lateral decubitus, or do you do it supine?
Both similar. Under MAG, they are left lateral decubitus, and even for my POEM, once they intubate them, I ask them to tell them to the.
Yeah, so you deliberately try to position them.
That wasn't deliberately for the flip evaluation. It's just more of my preference, but it worked well to answer your question.
Mm-hmm. Yes.
Hi, this is Vanessa Van Dreffen from the University of Chicago. I was wondering, just two quick questions. One, what type of general anesthesia did you use? Because I think that there are many kind of modalities that certain institutions use. And the second thing is, have you been able to use intraoperative flip for motility testing under general anesthesia? Has your institution been able to evaluate that?
So to answer the first question, the practice of our group mostly to induce with a paralytic, and then they followed that by propofol. Some cases they might end up giving general paralysis throughout, but mostly for the induction. So that's their protocol, but I didn't get exactly your second question.
Sure, and just for clarification of the first question, does your institution use halogenated like analgesics, or sorry, anesthetics like sevoflurane or isoflurane?
Not commonly, no.
Okay. And the second question is, have you been able to assess intraoperatively using FLIP, like the motility studies at all?
You mean outside of achalasia?
Even with achalasia, yes.
Yeah, so to use it under general anesthesia, it just doesn't give you different results. I think I'm struggling a little bit to understand the question, but I hope I answered it.
Yeah, the panometry rather than just the distensibility of the G junction.
Oh yeah, so we're looking at everything. We use FLIP 2.0, so we have both equipments, and we're looking at the panometry as well. Yep.
Okay, thank you.
No problem.
Yes.
Really enjoyed your talk. My question's sort of along the lines of the last questions as well. A long time ago when I was in training, we were told we shouldn't do manometry during sedation because of the potential impact of, say, narcotics or benzodiazepines on smooth muscle function. So might there be any other agents? First of all, I never bought that. Is there any data to suggest that these agents repair smooth muscle, and might that then be an explanation for your finding?
So yeah, I mean, I was thinking that I might get that question last night, so I tried to practice it. Our anesthesia might use fentanyl toward end of the procedure. They asked me if the patient will have pain. I said most commonly they do. So as for the purpose of this evaluation, there was no narcotics given at the time of the flip, right at the time of the poem. But generally speaking, and Dr. Corrales could comment on that, I don't think narcotics have effect on flip, generally speaking.
It's my bias as well. I'm just curious if there's anyone has any data on that.
All right, very good. Thank you very much.
Thank you.
Nice job. So next we have Daniel Schaudet, who's going to talk about robotic versus laparoscopic paraesophageal hernia repairs. Daniel?
Thank you, Lee. I want to thank the Society for giving me the honor to present on behalf of myself and my colleagues. So these are our disclosures. So the shortened esophagus, it presents a difficult surgical predicament in the setting of a large hiatal hernia repair. If untreated, shortened esophagus may lead to recurrence of hiatal hernias in the future. And shortened esophagus is actually more frequent than most of us perceive. There's been incidence reports as high as 19%. So what are the challenges and concerns about how to treat shortened esophagus? So there's really two pathways to go down. Either you do a higher mediastinal dissection, or you make the decision to perform a collis gastroplasty. Concerns over the collis gastroplasty, you're going to leave a little bit of aperistaltic neoesophagus and acid-secreting tissue above the fundoplication at times. Whereas with a higher mediastinal dissection, it's more of a challenge, primarily technically due to the poor visualization and theoretically because of the ergonomic difficulties with laparoscopic dissection when it comes to articulation and instrument reaching collision. So we hypothesize that the robotic approach reduces the need for collis gastroplasty by facilitating a higher mediastinal dissection as a result of better visualization and greater articulation of instruments. So our objective was to compare the rate of collis gastroplasty and long-term outcomes between the laparoscopic and robotic approach to paraesophageal hernia repair with fundoplication. So we performed a retrospective review of our database of paraesophageal hernia repairs with fundos at Cedars-Sinai. The operations were performed between 2013 and 2020. There were 3 surgeons amongst the group, myself included, and a collis was performed if there was less than 2 centimeters of intra-abdominal esophagus based on the intraoperative EGD when that decision is made. We had pretty good follow-up as far as our length of follow-up. It was 2.8 years. And our long-term follow-up included looking both within our EMR for results, as well as performing phone surveys to ask patients about their PPI use, performing a GERD HRQL questionnaire, and asking for patient satisfaction scores. So the results, we had 152 laparoscopic and 67 robotic cases over the time period. As you can see, the demographics were quite comparable. Age, sex, and BMI were all pretty similar between the 2 different groups. We looked at preoperative EGD and manometric findings. So the hiatal hernia size based on EGD was quite similar as well, 6.2 centimeters versus 5.7 centimeters in the robotic group. The percent of patients with esophagitis and Barrett's, which is thought to be a risk factor for shortened esophagus, was also equal amongst the 2 groups. And although it doesn't really predict shortened esophagus, the esophageal length on manometry was equal as well with a very similar range. We also looked at characteristics of the hiatal hernias on upper GI, And you can see that the number of small, medium, and large size hiatal hernias were equivalent between the two groups. So what we did find that was different was that there was a significantly lower callus rate amongst patients undergoing robotic versus laparoscopic hiatal hernia repair with fundoplication. You can see the number of revisional cases and percentage of revisional cases amongst the two different groups. Although there were higher number of revisional patients within the laparoscopic group, even when those patients were taken out, there was still a significant difference between callus rates between the two groups. The operative time was about the same, and the length of stay was 1 day shorter amongst the robotic group. So our perioperative outcomes, this includes all types of complications, including minor ones like UTIs or pneumonias, slightly higher predilection for the laparoscopic group, but not significant. There were 3 reoperations amongst the laparoscopic group, one for bleeding, one for a recurrent hiatal hernia, and one for a slip wrap. And the readmissions, you can see, there were 6 within the laparoscopic group and none within the robotic group. And as far as long-term outcomes, so the laparoscopic and robotic group had similar numbers and percentage of patients who were off PPIs completely, who had lower PPI usage. Their mean HRQL scores were also similar, and a satisfaction score where we asked the patients what their satisfaction rating was on a scale of 1 to 10 was similar as well. The limitations of our study, so it's a retrospective review. We did have a limited long-term follow-up despite all of our efforts, and in an ideal world, we would have had more objective studies to look at upper GIs and EGDs and manometries. Those of you who have done research know that these patients, it's hard to get them back when everything is going well for them. So in conclusion, both the laparoscopic and robotic approach to periesophageal hernia repair with fundoplication, with or without callus gastroplasty, were safe and effective. The robotic approach demonstrated a significantly lower rate of callus gastroplasty without any difference in long-term outcomes. Thank you very much.
Dimitri, we'll start with you.
Thank you very much, Danny. That was an excellent presentation, and I think a very important topic. You know, the myth of the short esophagus, the callus rate that your shop should have versus another shop, is something that many of us have actually written on, and everybody, of course, has their own opinion. So this data is very compelling because it clearly shows a difference between 2 techniques. My question is, did you look to see, is it the same surgeons or the robotic surgeons somehow, you know, getting more Wheaties in the morning and therefore are able to produce more esophageal length?
Well, so we actually had 4 surgeons, one of them being our senior partner. All of his surgeries were taken out because he only performed his operations laparoscopically. And it just so happens that he has a very, very high rate of callus gastroplasty, even higher than what you saw here, believe it or not. So the surgeons that were evaluated both performed laparoscopic and robotic repairs. 2 of us essentially went from laparoscopic completely to robotic, and the 3rd surgeon still has a sweet spot for laparoscopic surgery, so he still performs laparoscopic fundos as well.
So surgeons served as their own control, I guess.
Yeah, I mean, we combined the data all together, but even if you look at the 3 individual surgeons, you can see a difference between all 3 of them as well.
Well, then it must be the robot. Thank you.
Yeah, my question is along those same lines. It's always hard in comparing 2 techniques. Have they been done under the same timeline? Did you chart out how many were earlier in your experiences, your individual surgeon experiences, and how many were later? And how many of the differences relate to surgeon experience and are independent of the technique?
Yeah, I mean, I can talk for myself anecdotally, and I think even if we looked at the data as far as the timeline goes, I still perform colluses when I need to. We all perform the operations very similarly. We all come from the same lineage of training. As far as whether or not there's been a difference in collus based on our evolution of technique, I don't think there is. We didn't specifically look at that,
what I'm getting at is if early on you were all doing laparoscopic and then later you're doing robotic, then it's not fair to say that the robot was the improvement. It may be the speed. You got better at doing these operations regardless of the approach.
It's definitely a variable. I think it is. But I think for those that do robotic, you can clearly see that it's a much higher dissection you get with the robot than laparoscopic.
Yep.
But point taken.
I had a question. I don't know if I looked at this correctly in your slides. Did you say your rates of callus were 36 to 39% in your primary group and the same in the redo group?
In the laparoscopic, yes. Amongst the laparoscopic patients, so we had 11 or 12 out of 18 revisional in the laparoscopic revisional group that underwent
primary
callus.
group seemed to have a very high callus rate.
Yeah,
as well.
yes.
And so is there just are you introducing bias because your lap surgeons are just, has nothing to do with mobilization? Because it just seems like if we're doing a significant number of massive redos or type 4s, I can see that, but it just seems like such a high callus rate.
Yeah, it is. And we presented on this a few years back in JAMA Search. So our school of thought is that callus is probably underutilized. We really believe that performing a callus does decrease the recurrence rate, and I think that oftentimes we think that we have more esophagus intra-abdominally than we actually do. But correct, that is a bias of our institution.
No, I was just wondering, it's not that doing a callus decreases recurrence rate, it's just having enough intra-abdominal esophageal length that decreases the recurrence rate, right?
Correct.
It's not the callus per se, right? Just want to clarify.
I
That's
agree,
all.
yes.
Okay, question on the left.
Jocelyn Burke at UNLV. I'm assuming based on your last comment about not having objective outcomes, you can't comment on hernia recurrence rate in your long-term outcomes.
Correct. We had about a 50% long-term follow-up. So amongst the patients that we followed up, we got HRQL, we got satisfaction scores, and we got use of PPI. So those were our surrogate measures. We did have some patients that came back for testing. I would say probably less than 10%. But like I said, it's really difficult to get these patients to come back when symptomatically they're doing well.
So my second question is, did you take into account any other lengthening procedures that you did that were not just callus? Maybe your institution doesn't do any additional, but like mobilization of the vagus nerves or division of a single vagus nerve as opposed to doing a callus gastroplasty, or is the only lengthening procedure you do?
None of the surgeons divide the vagus nerve or anything of that sort.
So the go-to maneuver is the callus in all situations?
Correct.
Thank you.
Okay, one real brief.
A lot of questions.
Hopefully it's brief. Two technique questions. One, did you say you guys routinely, for all cases, do measurements of the GE junction endoscopically for all cases?
We do it if we're deciding between whether or not we need to perform a callus.
Okay.
So in the more obvious cases, we don't.
Okay. And then when you're doing, the 3 surgeons or 4 surgeons, when you're doing your case, you don't have enough length, were you able to determine if we don't have enough length, we're going to go back and do a higher mediastinal mobilization versus just going straight to callus?
Yeah, this is after the final mobilization, after the surgeon's decided that he's not going to mobilize any further.
Okay, thank you.
And most of us dissected up to the inferior pulmonary vein. So it was an extensive dissection between all 3 surgeons.
Thank you.
All right, thank you.
Thank you very much.
So our final paper to be presented is by Diego Romani. It's 3D CT gastric volumetry in sleeve gastrectomy patients.
Well, good afternoon. My name is Diego Romani. I'm going to present a new tool for revisional surgery and a follow-up of sleeve gastrectomy patients. Our team is from Lima, Peru, so I'm going to start. There is our question that was why we do this, where we were starting to do this exam to our patients. And it's because there is an exponential growth in bariatric surgery and also that has translated in a rise of post-surgical complications. The pathophysiology of anatomical changes after bariatric surgery and its impact on patients' long-term recovery has always been a matter of study, as we see GERD or weight regain after surgery. So our first hypothesis or question was, is weight gain regain related to sleep dilation? And we tried to measure the sleep dilation first with fluoroscopy and then with CT with oral contrast. But finally, we tried to do it with air and solid renderization of the gastric tomography. We tried to do it with effervescent salt, and this was from 3 months, and the last patient we did it was like 80 months in our follow-up. So you can see how we changed from the first patient until the last one. So for us, it's a very important diagnostic tool. One of the things that we find with our work, it was intrathoracic sleeve migration, most frequently reported as a surgical complication, not only in our center, if not in all area of Lima, Peru, and also a condition was associated with GERD symptoms. The first question was why weight gain was related to sleep dilation, but at last we find abnormalities and anatomical changes that we think that may cause GERD, as twisted sleep, total or partial sleep dilation, dilated esophagus, or in the sleeve, multiple areas of narrowing or kinking. We call kinking a forced angle between the body and the antrum. So you will see in the image. Here you can see in a solid and gastric renderization or reconstruction of the CT, dilated esophagus, in this case 4 centimeters, and stenosis or stricture in the incisura angularis. I'm going to pass to show you the results, and you can see better the images and our findings. So the most important thing in this work was to describe morphology abnormalities in post-sleep gastrectomy patients with 3D CT reconstruction, and it became secondary to calculate mean intraluminal gastric volume, but we think in the past, well, years past, we think that it was related to weight regain after 3 or 5 years. So in our methods, we reviewed 116 consecutive patients that underwent sleeve gastrectomy and postoperative 3D CT gastric volumetry. That's how we call the exam. And finally, we have 133, but we rechecked again the record and database and PACS to do again the work. So it's an easy, not difficult exam. They have to ingest effervescent salt without any water, immediately lay down on the CT, abdominal CT, and then we work with our technicians to do the 3D renderization in solid and air volumes. Air volumes are very important because I'm going to show you after this. I'm going to show you better the results. So our findings were kinking as a forced angle that I say between the body and the antrum was in 75%, intrathoracic migration 72, that was greater than we find in fluoroscopy with the same patients. And we also found incisura or stricture and incisura and fundus dilation. This is going to, you are going to see this better in the images. Okay, the mean gastric volume that went secondary, we find it 196 milliliters that range from 30 to 464, along 48 mean follow-up that we look for these patients. And we see that the gastric volume increases as the time passes. So here are two patients that we identified that's forced angle that we call, and that may obstruct the flow from the meal or acid and may cause reflux. And we see that these patients, most of them, more than 50% of them present GERD symptoms in the post-op follow-up. We found this kinking in 75%, almost 76. One of the limitations of this exam, we didn't not all patients we tried, but most of them came because they have some symptomatology or oral intolerance or vomiting. So that's we may found these abnormalities in a very abnormal rate. So we find also esophageal dilation that was 27.6%. As you can see, this may have been caused because intrathoracic migration or incisura stenosis. No. Here is an intrathoracic sleeve migration that we found is 72.4%. You can see in the in the volume and the left, the red lines that means the diaphragm. And in the air reconstruction or renderization, you can see the staples in red, or white and red, that goes above those red lines. And that's why we can make a better diagnosis of intrathoracic migration than fluoroscopy. And this helps us a lot in revisional surgery. So we found also fundus dilation of this patient. You can see one of them that's very enormous and big. We don't know really how it remains the stomach after the surgery. So it will be a good image in the fluoroscopy, but then a year or 2 years later we found this. So that depends in maybe how the patient eats, if they are the weight regain after all. The gastric body stenosis, you can see one of them, and also intrathoracic migration. And you can see the air volume to see it quite better. No, these are 2 patients. We have the images or the renderization of the 100 patients, so I try to choose the better ones to show you. And also the incisura is like 44%, that was pretty high. And that was our last patient. She came like a month ago, and we find that twisted sleeve, as you can see. There are 2 patients here. The first one, you can see in air and solid volume. Then the second one, just one of them went under revisional surgery. Not all of them want to go to revisional surgery, but we know that they are not going to improve with medication. So sometimes, and during this study, we find patients that said that they underwent sleeve gastrectomy, and we find very important things to talk, like a vertical banded gastroplasty, and as you can see also in the other image, a gastric banding patient with a enormous dilated esophagus. And also a SASI, a single anastomosis ileal sleeve, and a gastric bypass. We also try to check some patients that we have with gastric bypass that have reflux. And you can see the staples go above the diaphragm in the image there. So sometimes that helps us to know which type of surgery. And it's more important to us when it became from another center and we don't have a very good story from the patient. So we have some symptoms and manometric findings. When we find esophageal dilation in manometry, we find 66% of hypotensive less, 33 dysmotility, and 54 abnormal gastroesophageal gradient. In intrathoracic sleeve migration, postoperatively, they have 76 GERD symptoms. And I reviewed that 50% had previous hiatal hernia during the procedure, and they were performed hiatoplasty with mesh during the sleeve gastrectomy. So they migrate. We found gastric body stenosis. They have 70% report GERD post-op, and twisted sleeve patients, we have 10, and all patients report GERD symptoms postoperatively. And there were 2 of them that have oral intolerance and vomiting and desnutrition the first month of it. They came from another center. From all these patients, 9.5% underwent revisional surgery. Okay, our conclusion in our center is a simple, cheap, and feasible and non-invasive procedure. It's covered by the insurance company. And the 3D CT gastric volumetry is a remarkable diagnostic tool which allows surgeons to assess SG morphology in postoperative period for an adequate follow-up. And performing these tests, routine follow-ups, may help us to contribute the explanation of new onset gastroesophageal reflux symptoms and weight regain, maybe. That's all.
Thank you very much. Time for one question from the audience, if anybody has a question. It's amazing that your insurance company covers that. I don't think ours would unless it was checking for a complication, but
Yes.
Congratulations. So I think we need to move on to our next session, but want to thank all the presenters for taking an interest in submitting your abstracts. The research committee is grading you in the back, and tomorrow we'll announce a winner of the best presentation. So we'll see you tomorrow. Thank you very much.
Ladies and gentlemen, if you have not yet done your headshot, please make sure you see Jeff or Adam just outside of the general session area. Thank you.